No surgery is not a treatment plan until you know the exact tumor, the outcome being promised, and what happens if it does not work.
This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
Okay, but let me just jump in and ask the obvious practical question here first. If a patient is offered, say, a cream or some procedure that completely avoids a scalpel and stitches, isn't that just automatically the easier and better route?
Well, to figure that out, we have to look at Part 1, the exact diagnosis and risk. We really need to chart the clinical terrain before we can choose a route.
See, the decision is never just a simple surgery or nothing. Let's map out the first 4 of 7 core decision questions you've got to ask. First off, what exact diagnosis and risk group are we actually treating? Second, why does this specific tumor qualify for this route? Just saying it's easier isn't a real clinical answer. Third, what exact endpoint, like what measure of success, is being quoted to you? And fourth, how does the durable control compare over time? Because, for example, a partial biopsy might completely miss a deeper, more aggressive cancer cell, which would totally alter your choices. Moving right into the rest of these foundational questions. Number 5, what will the treatment reaction and the healing actually look like? 6th, how are we going to know if the tumor persists or comes back? And 7th, what is the rescue plan? These really frame the reality of your choice, right? Because going with a lower intensity treatment completely changes how you have to monitor the skin moving forward.
And that is exactly why getting the diagnosis right is paramount. Think of tumor types like completely separate highway lanes. A superficial basal cell carcinoma, squamous cell carcinoma in situ, which just means it's confined to the very top layer of the skin, and an invasive or recurrent facial tumor, they absolutely do not belong in the same evidence pool. You literally cannot take a treatment that's been validated for a shallow tumor and just assume it's going to cure a deeply infiltrative one. It just doesn't work that way.
Which brings us to Part 2, defining the treatment options or the different harbors of non-surgical care.
When you're evaluating these options, it is so crucial to understand that non-surgical isn't just one big bucket. It's a collection of completely different methods. These distinct docs include tissue destruction, like cryotherapy, which is freezing. Then there's immune stimulation using creams like imimequimod, and anti-metabolite medicines like topical 5-FU. It also includes light-activated treatments like photodynamic therapy, radiation therapy, specialized injections, and sometimes even deliberate observation. They all solve real problems, but they do it in entirely different ways.
Let's look at the trade-offs at each doc. Take ED&C, for example. That's electrodesiccation and curettage. A clinician uses a ring-shaped instrument called a curette to scrape away the crumbly, friable tumor tissue, and then they use electrical energy to basically burn or desiccate the base. It works quite well for select low-risk tumors. But notice what it trades away. You're left with an open wound to heal, and you do not get a tissue sample to definitively prove the margins are cancer-free under a microscope.
Radiation therapy is another distinct route. It treats the cancer in the surrounding field right in place. It can be a definitive choice when surgery just isn't medically appropriate or would create an unacceptable burden for the patient. But it frequently involves multiple visits, it can produce early inflammation, and even late pigment or texture changes to the skin. And again, it provides no X-sized margin specimen to confirm the cancer is 100% gone.
Okay, wait, let me jump in again. So if these specific methods avoid an incision, but we lose that surgical margin check, what exact outcomes are they actually promising the patient?
That is the big question. Let's look at Part 3, endpoints and real evidence. This is where we compare visible clearance versus 5-year success.
To answer your question, we really have to look at the hard evidence. A visibly clear surface after a couple of weeks is fundamentally not the same thing as a negative surgical margin or a 5-year success rate. Let's look at the absolute strongest comparative numbers we have from the SINS trial. For selected low-risk basal cell carcinomas, the 5-year treatment success was 82.5% with imiquimod cream. Compare that against 97.7% with standard surgical excision. That's a huge difference. And remember our boundaries here. Those numbers apply strictly to that low-risk population. They do not apply to high-risk facial or recurrent tumors.
And honestly, the exact method matters heavily, even when you stay entirely within the non-surgical lane. Just look at the data from the superficial BCC trials. 5-year tumor-free survival was 80.5% with imiquimod, 70.0% with 5-fluorouracil, or 5-FU, and 62.7% with photodynamic therapy, or PDT. So you can clearly see right there that not all creams and lights provide the exact same durable control.
Furthermore, we really have to respect how these studies are designed.
For instance, the nodular BCC PDT versus surgery study, that has to be understood strictly as a protocol-specific lesion-level result. It is not a Mohs cure rate, and it is definitely not a high-risk comparison. Applying that specific data to a high-stakes facial tumor would just be a dangerous mismatch.
All right, moving on to part 4, the healing and surveillance burden, or the hidden realities of no stitches.
You know, avoiding surgery doesn't mean avoiding a recovery period. When we break down the recovery timeline, we see the hidden realities of a no-stitches approach. Using a topical cream or light therapy can still involve weeks of intense inflammation, crusting, and soreness. Freezing the skin, that can cause blistering. ED&C creates an open wound on day 1. And honestly, all of these can result in later, permanent changes to your skin's pigment or texture.
Because most of these non-surgical methods lack complete peripheral and deep surgical margin knowledge, how we track the skin afterwards shifts completely. Surveillance becomes a mandatory part of the treatment. It's not just an optional extra. A surface that looks beautifully smooth and clear can actually still harbor a residual or recurrent tumor beneath the surface long after the initial reaction settles down.
Which leads me directly to asking about the backup plan. What actually happens if the cancer doesn't respond, or if it comes back later? That brings us perfectly to part 5, the rescue plan. It's all about charting the course when treatment fails. Well, if persistence or recurrence is identified, it can often still be treated. However, the salvage surgery might become much larger or a lot more complex. This happens because of the delay in getting definitive treatment, new scar tissue forming, or even altered tissue flexibility from prior radiation. Ultimately, a failed lower-intensity treatment can blur the border of the tumor, making it significantly harder to remove the second time around. So, the conclusion here is pretty direct. Simpler treatments can be excellent for carefully selected disease. If you have a primary superficial BCC on your trunk and you're willing to accept the weeks of inflammation and strict surveillance, knowing the cream offers lower 5-year success than surgery, that is a perfectly reasonable, preference-sensitive choice. But they usually trade away complete margin knowledge, and they absolutely do not match most surgery for a high-risk or anatomically important tumor. Informed patient preference matters most, but only once the exact diagnosis, risk, follow-up burden, and rescue plan are fully clear. The provocative question you have to ask yourself is, what exactly am I willing to trade away just to avoid a scalpel?
Your next step is to go read the complete Skin Trust article on this topic and discuss your individual decision with your treating clinician. I also highly recommend checking out the next Skin Trust explainer, What Makes Mohs Surgery Different. This really clarifies the choices. Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together.